Hi, it's Sunday morning. Andy and Alan here on Return to Healing, and we're going to talk about something that affects primary care, but it can affect the entire landscape of healthcare, which are these corporate kind of buyouts, or takeovers of groups of doctors, even hospitals, because the corporations are truly coming in. In my little world, Alan, uh, where I take care of, and I've been approached, my little practice has been approached, but we're not big targets for these groups. But the assisted living facilities and long-term care facilities are, and they are diving into them like vultures. And the crazy thing is, a lot of people are onto them, but a lot of people are taken in by what they promise, which is everything. They're going to come in there and they're going to provide every possible specialist in these long-term care things. By the way, we don't like specialists to come in to long-term care because they start doing stuff. But for instance, one of my friends, there's a group, it's nephrologists, a group of nephrologists or kidney doctors, but it's a big group, and they promise these facilities they'll set up a dialysis unit. They will not charge a medical director fee. They will bring in a bunch of specialists, mental health, all these other things. But their main goal and what they're selling the facilities is we're going to put all these people on dialysis. Likely many people who don't have to be on dialysis. And it's a win-win. These people are going to make a ton of money, and the facilities are going to make a ton of money from these machines. Hence, they kick out the primary care providers, which has happened multiple times, and basically make this into a dialysis factory. And it sounds very thorough. Everyone says, well, look at how thorough it is. They're bringing in all these specialists. That never happened before when it was just that primary care geriatric expert who was doing everything, who now is useless because he wasn't a big money thing. He was all about following regulations, keeping people out of the hospital, lowering medicine burden, all that kind of stuff. But the facility's making a lot more money this way. So that's been my experience. And we've actually been kicked out of a few facilities by these groups. And by the way, mostly there's a protest, but nobody cares. The administrators just don't care.
So Andy, I mean, you hit a couple of nerves there for me. So uh, I know we pick on cardiologists the worst, but when you actually think of the ethics of nephrologists, nothing when I have my palliative care hat hurts me more from a moral distress perspective as when you have this like 90-year-old person who comes in septic and multi-organ failure and now their kidneys are failing and they're going to dialyze them because their kidneys are failing, so therefore that's all they do. They look at the kidney and they do that. And the evidence clearly shows this kills people. Like you're killing them. Either they're going to survive or they're not. And then it gets even worse when they need to put them on pressors to get the dialysis. So not the topic of this talk, but you hit a nerve there. But the other piece is nephrology groups is one of the most expensive, and they're one of the leaders in private equity and venture capitalists taking over these dialysis centers. Many of them are corporately run, but you know, the crux of this, kind of the overview that that I like to talk about everything in medicine and about the quintuple aim of healthcare. So for the people who don't know that, it's about lowering the cost of healthcare, increasing the quality of healthcare, making it better for patients, making it better for doctors, and health equity for all. And private equity venture capitalist investment in healthcare does the exact opposite for every one of those. Okay. For every one of those five things that I just said, it increases the cost, it decreases the quality. Doctors are unhappier and leave these groups in drove. They work for each one for a couple of years, then they negotiate with somebody else. Patients are not happy because you're taking their choice away. And it adds to the healthcare disparities in something that I'll talk about a little later. So it's a lose, 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 lose when big business gets involved in something like this.
No, you forgot the win.
The,
The
the, the,
win.
the win is for their shareholders.
Yeah, the win is for them and their shareholders, and they have actually like these groups that are coming in to our places. They have no interest in patient care. It's not even what they sell to the facilities. There's no illusions there. They're going to make them money, and the money comes out of the system based on doing stuff that's unnecessary. But that's what they do. But what I found is they make promises that sound wonderful to everybody. And you're right, within 6 months, a lot of people are gone. The people working for them are gone. And I have nurse practitioners who've been wooed into these groups, and they think it's just amazing. And I've had people tell me you should do things this way. That these nurse practitioners, that why don't you change your practice to this model? I'm like, no, it's a self-serving corporate model that doesn't care about patients. In the end, it will make money for all the wrong people, which is kind of the entire problem of our healthcare system is that we are feeding money to groups that have, including the pharmaceutical industry, groups that have no interest in patient care, but pretend to. And that's the whole thing, Alan, that I was taken in by is how good they are at marketing themselves. And some of it's like they give this package of analytics. Like they could show all these graphs that they're going to print out. Oh, this is how many people fall. This is how many people. But we know this inherently. We understand how to prevent falls, and these guys are giving the graphs, but on the other hand, doing everything to make sure falls increase because this is how because they're medication fiends.
That's right. And they love the NPs and the PAs because one, again, the cost to pay them is lower. Their skills are lower, I'm sorry, and they refer more. So the evidence is clearly that, allied health physician PAs and advanced practice nurses refer more because they don't have the knowledge to handle many of this themselves. And this is exactly what these patients want. They want to drive up the utilization because that's how they make their money by increasing utilization. And when you see the things they buy up, they only buy up primary care for the covered lives. What I mean by covered lives is many people on these Medicaid and even Medicare Advantage plans need a PCP. And if you don't have a PCP, then you don't have those patients. And some of these are the most valued patients in healthcare. And I'll give a story about one near our hospital. But they only buy up the PCP practices, the primary care for the covered lives. What they really want to buy up are these anesthesia groups, interventional radiology groups, GI groups, and the dialysis centers and stuff, because those are the procedures and things in medicine that make them the most money.
Yeah, and that's really what they're selling. I got to tell you, in my world, you talk about people showing up to the hospital in grave danger, get being dialyzed unnecessarily. In my world, it's people who are sitting around with a high creatinine because they're old. By the way, that's how they measure kidney function, which is completely invalidated in older people. But they 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 pluck all these out and say, you're going to die. You need dialysis. And these are people who are doing just fine staying away from these vultures. But once the vultures buy the place or get into the place, they just set up these centers, and all of a sudden everyone thinks they need this dialysis, which kills them. I mean, for an older person with dementia, it's horrible. And the other thing they sell, and I don't know if this is something you found, Alan, they come in there specifically to sell their health insurance. A lot of these
Exactly.
people have their own product, their own health insurance, and their whole goal is they're going to get as many people in these facilities to sign into their health insurance. Again, with great promises. If you sign up, you're going to have all this stuff. And if they don't get that, they just leave. They're gone and they leave the facility high and dry. But if they get it, they start having basically a two-tiered system. The people who are on their health insurance and the other people who get completely shanked from by these groups, and it creates this weird dichotomy of class that I've never seen before.
No, you're absolutely right. The system, the fact that this is allowed is unbelievable. I wanted to look before we go on. I doubt like this happens in law. Law is the lawyers own their groups. They wouldn't allow some company to take them over. But I could be wrong. I don't have the facts on that. But I want to give a little story about some of the groups by us. So, I don't know if you've heard of some of these groups called Chen Med or Oak Street Medicine or Oak Street Healthcare. Oak Street Healthcare is something that was actually taken over by CVS, and they actually closed a bunch of them. But what they do is they cherry pick the patients. What does that mean? they only select certain health cares that are Medicare Advantage plans, which pay the most, and dual eligible. Dual eligible means patients have Medicare and Medicaid. So that's kind of like the golden patient for them because they get the full amount of money for both the Medicare and the Medicaid. They don't have to worry about copays and deductibles because Medicaid picks it all up. And what they do is go in and they don't accept straight Medicaid. So straight Medicaid is for the poor, underserved patients in this world that don't have, and they don't take those patients. So they're blatantly discriminating against and only taking patients that either have Medicare or Medicare and Medicaid. And what does that do to the local institutions around? It takes the patients away from hospitals in the underserved that are really serving the underserved. Okay. It takes those well-paying patients away and leaves them the poorest Medicaid patients, making the poorer hospitals poorer and poorer and poorer, while they get richer and richer and richer, these venture capitalists, but they don't run them right. They run them to the ground, and then they get taken over by someone else. This is going on all over the place.
Yeah, and I have found that the patients and their families, even some of the directors of facilities who I used to respect have no clue about what, they're kind of bought into this idea that these people are here to offer them something amazing and wonderful. It is just um such a scam almost. I feel like, when I push back against this stuff in my little world, I feel as though people are looking at me like, oh God, you're so old fashioned. This is, look at them, they have analytics, they use words like AI. It actually is no meaning at all in medicine, believe me. AI, but not yet. We don't have the robot doctors yet. But they use it and they feel like they're, all these like CEO people are just blown away by all this, by the presentation. And you're right, Alan, as the whole thing fails, which it does, the nurse practitioners join these groups in droves. And what you're saying is true there, that in my experience as well. But it's been shown that they're gonna refer. I see nurse practitioners who were, doing the geriatric thing, leap in and become kind of the sidekicks of these groups and rise up, because they're doing so much referring, and they're like, there are vascular groups that have done this. Vascular group, if anyone doesn't know, or deals with veins and arteries and blood flow. But all of a sudden, they're sending people around. These nurse practitioners are flopping in here in the facilities and finding everyone has vascular disease and referring everyone out to the surgeons. Again, that's their job. Their job is to pluck people, and only the well-insured. So you're going to go to facilities that have a lot of well-insured, or you're going to just pluck enough of them from the facilities and ignore everyone else. By the way, Alan, ignoring those who are ignored, um, if the facilities have kicked out the previous primary care group, those ignored often have to leave the facilities to find help, to go find the doctor. They're kind of saying, well, join or die is kind of the way it is. But in the end, they probably get better health care than the other ones, sadly, because they're
So,
not being put into this morass of specialization.
so you hit two more nerves for me. Um, they opened up two groups in New York are taking over as well, which you wouldn't think about. They call them the dermatology specialists. Entirely, there's not a doctor in any one of these they're like boxes, like Taco Bell. Like you go in there, you get something taken off by a PA or a nurse practitioner, and you move on. And 90% of these things don't need to be moved on. But the one that aggravates me the most are the vein centers. So in New York, on every corner, there's either USA Vein Center or Metropolitan Vein Center. And those centers are purely, no one walks in there without arterial vascular studies, venous vascular studies, and a procedure. 90% of them are totally unnecessary. And I just had a personal experience. So I make a home visit on one of my colleagues' dads, okay? I'm their PCP. The guy is 85 years old. He's morbidly obese. He could essentially walk from his bed to the bathroom. That's it. He gets recurrent venous stasis ulcers in his leg. So that means the blood goes down, but it doesn't come up. So I told them they need to get a home care podiatrist because I can't take care of his toenails, and his toenails are leading to cellulitis, which is a local infection. So they find a home care podiatrist because they live in an area where I actually don't practice out on Long Island. And the guy comes in, and what does he do? Arterial and venous studies on an 85-year-old, essentially bedbound man that walks to the bathroom and has no symptoms except recurrent infections because he's not getting his feet taken care of. What does the podiatrist do? He refers them for a vascular surgeon because they need vascular surgery when the study came back plaque in the vessels. Plaque means no obstruction, plaque. And he wants this guy to have surgery. So I called the guy up. I'm like, but he's got asymptomatic peripheral plaque. Why would you do surgery? Well, that could lead to limb loss and toe loss. Like the podiatrists have bought the Kool-Aid, and I'm convinced they must be getting a kickback for every referral. Like it's got to be.
And that's what I do think there people are in cahoots in the specialty world. Alan, you and I are never included in the in the
That's
cahoot.
why we're poor primary care docs.
Exactly. We push back. They don't want to hear anything like that. And you can convince a patient of anything that they're going to lose their limb if they don't do this. It's fear. Like I've always said, fear is the driver of the whole healthcare system, and people so fear being sick or dying. But yeah, there's no evidence any of those interventions prevent anything. The way the podiatrist that you mentioned spoke, it's like, well, he could have something. It reminds me of a comedian who is told he has prediabetes, and the comedian's like, "Do I have diabetes?" He said, "No, you have prediabetes." And he says to the doctor, "Do you have diabetes?" Doctor says, "No." And he says, "Well, I guess you have prediabetes too." And he said, "I guess we both have pre-death, right? I mean, that's a condition, but everything's pre, right? Let's do it just in case. Let's do it because you might get this." Even though you're 85 years old and we're just trying to keep you functional and do what needs to be done to make sure you can live a long life and not get sick, they're going to make you sick with these promises. But again, these people are in now the corporate world. So they've been bought up by corporations, a lot of these specialists, and now they become these vultures, and they're like the front people who make the promises. And yeah, it just it it's a funny thing about our healthcare system. The more inefficient and dangerous it is, the more it pays well. But these guys are making sure, especially in these long-term facilities I'm in, and I'm sure this is true in hospitals, that they're not the only ones getting paid well, that the administrators in these places are also going to be paid well. And so no one cares about patient outcome. And it's not measured. It's just
Yeah.
the only thing measured are these analytics, which are meaningless, and the dollars coming in. Those are the measurements, unfortunately.
And they don't measure the mortality rates either.
Never.
So evidence clearly shows when these folks come in, whether it's a nursing home or a hospital, they're looking to cut costs so they make more money. It's about profits over patients. And when you do that in the healthcare, you get more hospital-acquired infections and you get higher mortality rates. Like the data clearly shows that in both hospitals and in nursing homes.
And all that makes you before the death occurs, the unnecessary death occurs, there's a lot of suffering, uh, which leads to a lot of intervention, which leads to a lot of profit. And I hate to be so cynical, but
No,
if they
you
make
like being cynical.
but if they make you sick, they make more money. We're kind of the only field like that. We're the only field if we screw up, we actually do better financially. Not us, not you and I. We're like we have no incentive in this game.
Yeah, we are a sick care system. You don't
Yeah.
make money on healthy people, these corporations. They want sick people.
They absolutely want sick
The,
people.
the, the Medicare Advantage plans pay more if you're sicker.
They
So,
absolutely do. They're
so even if
coded.
they're not sicker, make up some diagnoses so you could increase the codes to make them sicker so you get paid more.
And there are codes. We all know them. This is what we put in if we have to, and the Medicare Advantage plans love that. But also these doctors invent sickness. That's how you do it. You invent sickness. You tell someone that they're sick. Done a bunch of tests, and you need this, that, and there. We got the endocrine MP coming in now. We got the cardiology MP coming in now. wow, I never had such thorough care as this. This is amazing. I didn't realize when this last schmuck was seeing me, he didn't tell me I had stage 3 kidney disease and that I might need dialysis tomorrow. He said it was normal for someone my age, but these guys say I could die by tomorrow. It's this fear mongering, and these groups come in and invent sickness all over the place,
Let, let-
with in the well insured.
let me give a quick story from my hospice and palliative rounds on Friday. My team was perplexed. They consulted on like a 95-year-old who was totally independent, lived at home, had some visiting nurse come in a few times a week, and her family come in and get her food, but she wanted to be on her own, alone. Ambulates with a walker, pretty independent and with it, and obviously at 95, you're going to be forgetful and this and the other thing. And she gets admitted for like decline in functional status. She fell. She didn't break anything, but they do the workup and find out, you know, nothing specific wrong. She didn't break anything, but the team doesn't understand like what happened to her. Why did she deteriorate? And like I'm looking and I said, nobody knows why. I was like, she's 95 and she fell. Okay. Like, what's the number one cause of death in a 95-year-old that falls? Falls. Like, we need to label everything with a diagnosis like getting old is not a reason to die anymore. You can't just die because you're old.
Well, it's Norton Hadler, whose book Rethinking Aging. He says age is now a disease. That has an ICD-10 code. Now every aspect of age is now a disease. Even wrinkles has a code that you could say is a diagnosis. You're not allowed to age. Every part of aging is a sickness that can be addressed by a specialist. And these big groups will make sure to do that. While you and I, Alan, we say, don't worry, you're fine. You just don't fall anymore. Let's work on you not falling. Well, they say, no, you got severe osteoporosis. You need these
Yeah.
infusions. You need this. You need that. It's
Oh,
like,
so
wow.
one of my favorite ones, there was a push around our community, from the consultants, they come in to increase the billing that you get. Senile purpura. So senile purpura is, your skin gets thin when you age, your platelets go down, your clotting goes up down a little bit, and you get bruising. And all the little old ladies and little old men have bruises all over them. And, it's just getting old, you're getting
All
bruising.
normal. Yeah.
What if you put the diagnosis of senile purpura, you get like an extra $100 per member per month.
Yeah,
It's
right.
like,
That we have to diagnose everything. It's almost like people can come into your office with this list of 20 problems when they're completely healthy. They're just old. And we've just gotten good at this. And again, these are what these firms, these specialists really pounce on because they're going to get paid more if they give you more sickness.
yeah,
And so that's what they do. They sell sickness and it makes the facilities richer, them richer. And sometimes the saddest part to me, Alan, is sometimes the patients and their families think they're getting more thorough care when this happens because people are meddling more into them and they figure that's a good thing. And that's just the opposite of what reality is.
yeah,
But we
agree.
we look pretty bad when we say everything's normal and then the specialists come in and say, your primary doctor missed these 8 diseases and we now have specialists for them and we're going to give you medicines for them. And they're like, God damn, I would have died if I stuck with them.
Absolutely.
But that's one of the reasons primary care is dying because what we're selling, which is common sense, compassion, and science, is not what they want to
Yeah.
buy.
We're just a sick care system for the folks who are watching this. Please get our book, A Return to Healing. You could either go to Amazon, Return to Healing, or you could go to our website, returntohealing.com. And this is all we talk about. We talk about a sick care system that's about, profits over patients and, just bad care. People don't realize how bad it is. It's not just about the finances and the fighting in Washington now. It's about bad health care.
And the bad healthcare, as the cost of it goes up, the longevity goes down, and all the parameters of good health. People are sicker than ever before. The more we spend on them, and no one seems to see this dichotomy. But in the book, we lay out that not only stories of our own practices and patients, but we lay out the actual facts. We document everything, and it's pretty remarkable how they really put wool over everyone's eyes, and created a system that profits them, like you say, a sick care system that is not helping them one bit. So anyway, Alan, we'll we'll leave it at that, and then we will reconvene next Sunday.
All right, sounds good. Everybody
Okay.
have a good week. Take care.
Take care.